So the lower eyelids and the upper eyelids have completely different anatomic problems, and even though people quite commonly notice ageing of both, it's also quite common for people to come and talk about one. With the lower eyelid, the problems people have tend to be the development of fat bags, the development of a tear trough, which is a hollow or a line, which can also cause shadowing at the junction of the eyelid and the cheek. And it can also be that the cheek itself looks flat and there are folds on the cheek, such as I have given my age, which can also create a sense of ageing. On top of that, there's also problems with lower lid support and weakness from a muscular point of view. And there's a great variety of people's skull shapes. Some people have deep set eyes, which we kind of like in eyelid surgery, or more prominent eyes which push forward beyond the bony rim of the eye socket. We call that a positive vector if the eyes are deep set, and a negative vector if the eyes are more prominent. And patients with a more prominent eye actually have a higher risk of lower lid surgical complications than eyelid surgery. Understanding the basic anatomy of the eye is important. It's also important for us to understand the history of ageing of that individual and whether they've got any eye disease. In looking at the eye and addressing the bags and the tear trough and the cheek, we don't look at the lower lid as a single unit, or rarely. Need to understand what's going on. For example, if someone's got a fat bag and a tear trough and we just remove the fat bag's gone, but does the eye look any younger? It doesn't necessarily, because the tear trough is still there or the tired looking cheek is still there. As we age, what happens is this: when you start off as a teenager, if you look at teenagers, they really don't have lower lids at all. What they've got is cheeks that go really all the way to the eyelid margin. Structurally, as time goes by, almost the first sign of facial ageing that we see is some change in the lower lid and the lower lid cheek junction. So it's something that people become conscious of. If you look at someone who's 20 and 35, their face is likely to look very, very good, perfect at 35, but you'll probably start to see some early eyelid changes. It's often the first thing, as I say, that we see. What's happening is that the malar fat pad or the cheek fat pad starts to descend a little bit. The eyelid structures, which hold the intraorbital fat in back behind the bony rim and so there's no fat bag, begin to weaken. And the weight of the eyeball sitting on this little fat pad in the eye socket just gradually can push out the fat over the bony rim of the eye socket, creating fat bags. And there's 2 or 3 compartments of the lower lid that we see these fat bags in. Also, the lid structures can begin to stretch to an extent, and the skin loses a bit of elasticity, so you get some fine crepey wrinkling. At the same time as our cheek descent happens, it exposes the orbital rim, which has been kind of covered by fat up until that point. So the ageing changes don't usually or aren't due to an accumulation of new fat. It's just a gradual separation and expansion of the orbicularis muscle and the cheek and the lid, which create the elements of it that are hidden and tight become looser and more visible. So as surgeons, we don't think of eyelid aging as eyelid aging at all. We think of it as cheek lid aging of the lower lid, and we need to address it all. Otherwise, we don't do a good job and succeed in the aim of giving you a refreshed looking lower lid appearance. If you think about the teenage lower lid that we were talking about earlier, there's a smoothness to it. It photographs well. As we age and these structures stretch and descend, we get lumpiness. And ultimately, lower lid surgery, and this is a key point, is not about tightening skin. If you tighten skin over a lumpy base, you'll do 2 things. You won't fix the problem, and you'll create a new problem of a short lower lid with a starey eye. Most of the visual stigmata of eyelid surgery giving a starey or unappealing or frightened or surprised look don't relate to upper lid surgery. It relates to lower lid surgery where there's been excessive tightening of the lid, causing a short lid with exposure of the pupil or the white of the eye, rather the sclera, the white of the eye below the pupil. And if your eyes widen in shock, that's what happens. So it's an important thing to get your head around that we're not going to be talking about skin tightening in a lower lid consultation. What we'll be talking about is how do we make the transition from your lash line to your mid-cheek smoother. And if we can do that and the skin drapes over it, you have to accept that you've got some aging and crepiness of the skin. It's normal and often photoshopped out of magazine models of middle age, and so you get a false impression of what these people actually look like. You need to have a little bit of soft skin there in order to have a long lid and a normal, non-surprised appearance. But the elements of assessing the lower lid are to look at the lid strength, the muscle, whether there's any true skin excess, the fat bulges that come out above the bony socket, the orbital rim itself and correction of that if you have a shadow or a hollow there, and then the cheek position. It's rare for us to remove fat from lower lids now. 20 or 30 years ago it was commonplace, but now we don't do it. We've realised you might remove the fat bags, but you create a hollow looking aged eye. You don't create a youthful eye. Youthful eyes are full, they're full of smooth fat. They're not just hollow and they're not lumpy. So our aim is to try and restore that. This is done usually through lower lid procedures which create an incision just at the bottom of the eye, lifting up the skin and the orbicularis muscle to expose the deeper structures, the orbital septum, the fat bags, the orbital rim and the upper cheek. And by essentially redistributing the fat, supporting the cheek structures, sometimes even fat grafting or adding augmentation to the cheek itself, it's usually possible to create a smoother transition from the upper cheek to the lower lid. When that's done, the skin and the orbicularis muscle sheet are redraped very conservatively, and if the lid itself is weak, then sometimes it's strengthened through an additional procedure called a canthoplasty, done at the same time. So we're aiming to get a smoother appearance from the lower lid to the mid-cheek, aiming to get skin redraping in a way that creates not wrinkles and lumpy skin, but adequate amount of skin, and if that's got little wrinkles on it, then so be it, to have a non-tight looking lower lid appearance that does not pull the eye off the globe and give you a terrible red rimmed eye, or create shortening which will give you a starey eye. These are the things we worry about. Complications and risks of lower lid surgery are much more problematic than those of upper lid surgery, because essentially what we're trying to do is to hold the lower lid up onto the eye against gravitational force and the weight of the face pulling it down. And so it's trying to be overly aggressive with tightening these structures near the eye that may add to the complication risk of lower lid surgery. And so understanding the potential negative consequences of lower lid surgery are really critical in any professional assessment of lower lid problems, and creating a surgical plan that provides improvement but does not give you new problems, some of which are difficult to fix. And that's the aim of lower lid surgery in my practice.